There is something sitting in your medicine cabinet right now that your doctor probably hasn't flagged, your pharmacist likely hasn't warned you about, and that millions of Americans over 70 are taking every single day without any idea of the real risk they're walking into. And the most alarming part? 3 of them don't even require a prescription. You can walk into a drugstore, pick them off the shelf, hand over a few dollars, and take them home tonight. That ease of access is exactly what makes them so dangerous. Because when something is that simple to obtain, we stop treating it like a drug. We treat it like it's safe. And for a body that has crossed the threshold of 70, that assumption can be the difference between living independently and ending up in a hospital bed, wondering what went wrong. Here is what most people are told, and why that advice is dangerously incomplete. The standard guidance has always been that if something is approved by the FDA, available at your local pharmacy, and widely used by millions of people, it must be safe for you. That assumption made sense once, but it was built around data collected primarily from younger adults, and it has never been adequately updated to reflect what happens inside the body of someone who is 70, 75, or 80 years old. The science has changed, the recommendations have not kept pace, and the people who are most at risk are often the last to hear about it. This isn't a new problem either. Geriatric medicine has known for decades that the aging body processes medications in fundamentally different ways than a younger one does. That knowledge exists in medical journals, in specialty guidelines, in the training of geriatricians across the country. But it hasn't made it into the 15-minute primary care appointment where most seniors actually get their prescriptions. It hasn't been explained clearly at the pharmacy counter. The gap between what researchers know and what everyday patients are being told has existed for years, and during that time, countless older adults have been harmed by medications they were never fully warned about. That is not a minor oversight. That is a systemic failure that deserves to be named directly. So why does it matter so much right now? Because the consequences are not abstract. We are talking about falls that shatter hips and end independence. We are talking about kidney damage that develops silently over months without a single warning symptom until it is already advanced. We are talking about cognitive decline that mimics early Alzheimer's disease, that pulls a person away from their family, their memories, their sense of self, often caused not by aging alone, but by a medication they've been taking every night for years, trusting that it was helping them. The stakes here are not small. For adults over 70, the wrong medication used long-term is not just a health inconvenience. It can fundamentally reshape the final decades of a person's life. And that raises some questions worth sitting with. Why, if the research has been available for this long, are these medications still being handed out to older adults without adequate warning? Who is responsible for updating the standard of care when the evidence changes? Why does a 73-year-old woman in a 15-minute appointment with a busy physician have no realistic way of knowing that the sleep aid she's been taking for 4 years may be slowly eroding her memory? And how many people right now watching this are taking one of the medications I'm about to describe, completely unaware of what it may be doing to them? What I'm going to share with you is not fringe medicine. It is not alternative health advice. It is mainstream geriatrics, grounded in peer-reviewed research, published in respected medical journals, and formally recognized by the American Geriatric Society, which maintains the Beers criteria, a regularly updated, medically reviewed list of drugs considered potentially inappropriate for older adults. This list exists because the evidence demanded it. I'm Dr. Sarah Mitchell, and this channel is dedicated to translating that kind of research into practical, actionable information for adults over 60. If you haven't subscribed yet, please do. We publish new evidence-based content every week designed specifically for you. Now let's get into these 5 medications, and more importantly, what to do if you or someone you love is currently taking any of them. The first category is benzodiazepines. You probably know the brand names better than the drug class. Xanax, Valium, Ativan, Klonopin. These are prescribed primarily for anxiety and insomnia, and they do work in the short term. That effectiveness is part of why they're so widely used, and it's also part of why they're so consistently problematic for older adults. After 70, the brain's sensitivity to benzodiazepines changes significantly. The liver metabolizes these drugs more slowly, which means they accumulate in the body. A dose meant to help you sleep at 10 in the evening may still be impairing your coordination when you get up at 3 in the morning for a glass of water. Multiple systematic reviews confirm that benzodiazepine use is associated with a substantially increased risk of injurious falls in older adults, falls serious enough to require hospitalization. And falls are the leading cause of fatal injury in adults over 65 in the United States. We are not talking about a minor side effect. Beyond fall risk, benzodiazepines consistently impair memory, attention, and executive function in older adults, even when people feel they have adapted to the medication. If you are currently prescribed one of these, please do not stop taking it suddenly. Abrupt discontinuation can cause serious withdrawal, including seizures. This is a conversation to have with your doctor about a supervised gradual taper. The second medication on this list genuinely shocks people because it costs about $6 at any drugstore. Diphenhydramine, sold as Benadryl for allergies and as the active ingredient in Zizquil, Unisom, and Tylenol PM. Millions of older adults take this every single night, confident that because it's available without a prescription, it must be safe. It isn't. Not after 70. Diphenhydramine is one of the most potent anticholinergic drugs available over the counter. Anticholinergic means it blocks acetylcholine, the primary neurotransmitter your brain uses for memory and learning. Interfere with that chemical nightly for months or years, and the consequences are serious. A landmark prospective cohort study published in JAMA Internal Medicine in 2015 followed more than 3,400 adults aged 65 and older for over 7 years. Researchers found a clear dose-response relationship between cumulative anticholinergic drug use and dementia risk. Those in the highest use category had a 54% increased risk of developing dementia compared to non-users. A 2019 study looking at nearly 60,000 dementia patients corroborated those findings. The evidence has continued to build every year since. Eleanor was 71 and had been taking 2 Benadryl tablets every night for nearly 5 years. Her doctor had actually suggested it for sleep. Over those years, her family watched her become increasingly forgetful. A new geriatrician reviewed her medication list, flagged the diphenhydramine immediately, and guided her through stopping it. Over the following 7 months, Eleanor's cognitive test scores stabilized and partially improved. Her daughter told me it felt like getting a piece of her mother back. The third medication is one that tens of millions of seniors reach for the moment their knees or back flare up, and the kidney damage it causes develops silently without a single symptom until it is already advanced. Ibuprofen and naproxen, sold as Advil, Motrin, and Aleve. These non-steroidal anti-inflammatory drugs are the first response to pain in most households. For occasional use in younger adults, they're generally manageable. For regular use in adults over 70, the risk profile changes entirely. Your kidneys are responsible for filtering these drugs from your bloodstream. After 70, kidney function has typically declined by 40 to 50% compared to young adulthood. When ibuprofen circulates in a body with already reduced kidney function, it lingers much longer, hits much harder, and progressively damages the very tissue responsible for clearing it. The 2023 update to the American Geriatric Society Beers criteria specifically reinforced the need for renal function-based dose adjustments for NSAIDs, recognizing how frequently this class causes acute kidney injury in older adults. The gastrointestinal risk is equally serious. According to the NIH, older adults who use NSAIDs regularly are 3 to 5 times more likely to develop a serious gastrointestinal bleed than younger users. And for anyone with heart disease or high blood pressure, NSAIDs additionally raise blood pressure and increase fluid retention, elevating heart failure risk. This trifecta is what makes ibuprofen and naproxen particularly dangerous as a daily or near-daily habit after 70. For senior joint pain, acetaminophen used correctly, no more than 3,000 milligrams total per day for adults over 65, is significantly safer for kidneys and the gastrointestinal tract. The fourth medication is prescribed to roughly 10 million Americans annually for sleep: Zolpidem, sold as Ambien. The FDA issued a specific safety communication about this drug and older adults, noting that elderly patients can have far higher blood concentrations of Zolpidem the morning after taking it compared to younger users taking the same dose. This means they are still pharmacologically sedated when they wake up, without knowing it. They feel like themselves, they don't feel drugged, but their coordination and reaction time are compromised. Research consistently finds that Zolpidem use is associated with nearly twice the risk of hip fracture in older adults. Hip fractures in adults over 70 carry a one-year mortality rate of 20 to 30%. That means up to 3 in 10 seniors who break a hip may not survive to the following year, often due to complications during recovery. There is an additional problem. Zolpidem suppresses the deep restorative stages of sleep while increasing lighter sleep stages. So you fall asleep faster but wake up less restored, which drives continued use, higher doses, and dependency. The better alternative for long-term sleep difficulty is cognitive behavioral therapy for insomnia, known as CBTI. Studies consistently show it outperforms every sleep medication for long-term outcomes, with 0 drug interactions, 0 dependency, and no morning impairment. Ask your doctor for a referral. The fifth medication surprises more people than any other on this list: proton pump inhibitors, omeprazole, Prilosec, Nexium, Prevacid. These are among the most widely prescribed drugs in the world. For short-term use, 4 to 8 weeks, they are appropriate and effective for acid reflux and stomach ulcers. The problem is that most seniors are not taking them for 8 weeks. They have been on them for years, sometimes decades, without any reassessment. Long-term PPI use after 70 quietly depletes 2 critical nutrients. First, vitamin B12. Your stomach acid is essential for absorbing B12 from food. Suppress that acid for years, and B12 absorption drops sharply. Research published in JAMA found that long-term PPI use was associated with a 65% higher risk of B12 deficiency. In seniors, severe B12 deficiency causes peripheral neuropathy, the tingling and numbness in the hands and feet, as well as cognitive decline that mimics dementia. Second, magnesium. The FDA issued a specific safety communication warning about dangerously low magnesium in long-term PPI users. Low magnesium affects heart rhythm and nerve signaling in ways that compound other cardiac and neurological risks in older adults. Robert was 76. He had been on omeprazole for 9 years, originally prescribed for an ulcer that had resolved long before. His B12 came back critically low. His geriatrician tapered him off the PPI over 8 weeks, started B12 replacement therapy, and shifted his reflux management to dietary changes. 4 months later, his neurological symptoms were clearly improving. 9 years of an unnecessary prescription, identified with 1 thorough medication review. So here is exactly what to do after watching this. Write down every medication you take, prescription and over-the-counter. Yes, that includes Benadryl. It includes the Advil. It includes the Prilosec. Over-the-counter does not mean safe. Bring that list to your doctor and ask specifically for a geriatric medication review, requesting evaluation against the American Geriatric Society Beers criteria. Those exact words will be immediately recognized. If you have been on a PPI for more than 6 months, ask whether you still need it and whether your B12 level has been checked recently. If pain management is a concern, ask about acetaminophen as a first-line alternative. If sleep is the issue, ask for a CBTI referral before accepting another prescription. One final note before we close, and this is important. Do not stop any prescription medication without speaking to your doctor first. Benzodiazepine withdrawal without medical supervision can cause life-threatening seizures. For anyone managing heart disease, kidney disease, or multiple prescriptions simultaneously, any medication change requires careful, coordinated medical oversight. These 5 medications are not automatically dangerous for every person in every situation. But in adults over 70, used long-term without reassessment, the research is consistent. Your body has changed since you first started taking some of these drugs. Your medication list may need to catch up. Thank you for spending this time here. This kind of information matters, and you deserve to have it. Next week, we are covering 5 supplement combinations that are quietly dangerous for seniors, including combinations being sold together in the same bottle as though they are perfectly safe. That video could genuinely protect someone you love. I'm Dr. Sarah Mitchell. Take care of yourself.